Uh, it's my distinct pleasure to welcome our esteemed speaker this morning, Dr. Kris Moe, for our department's Grand Rounds. Dr. Moe is a leader in the field of facial plastics and reconstructive surgery and skull-base surgery. He completed his residency at the University of Washington and then did two fellowships, one in facial plastics and another in skull-base surgery, both in Switzerland, one in University of Bern and then at Zurich. He was faculty in Zurich, and then he transitioned to UC San Diego, where he was there for many years before returning to the University of Washington in 2005. He now serves as the chief of the Division of Facial Plastics and Reconstructive Surgery there. He's a dedicated teacher, having won multiple teaching awards, both at UC San Diego and University of Washington from the residents, and he's won multiple research mentorship awards at UW. His research is focused on computer-aided surgical planing, devices to increase surgical safety and patient protection, and new minimally disruptive surgical approaches. He's published on facial reanimation, facial nerve regeneration, and outcomes in reconstructive surgery. And he's the co-founder of Surgical Pathway Innovations, which is a company that's focused on developing a flexible endoscopic robotic operating system and relevant medical devices, has received over $1 million in funding from the Department of Defense and has multiple patents. So thank you so much, Dr. Mo, for sharing your expertise and insights on surgical innovation, and we look forward to your talk. Thank you so much.
Well, thank you very much, Dr. Lindberg. It's a huge honor to be here. I really appreciate the invitation from you and Dr. Nade, a great friend of mine, and hello to my many other friends on your amazing faculty. Disclosures, some of the illustrations and a bit of the discussion will come from these books, and I'm a founder and equity holder in Spyway as well. Topics. This is a new lecture that I'm giving for you guys, so hopefully the timing and everything is going to go well. But it's really exciting because Dr. Lindberg asked me to discuss devices to increase surgical safety and innovations to solve surgical problems. And these are really what my career is about. So I'm going to discuss these things, talk about how innovation can work well in your career, talk about some unusual topics in facial plastic and skull-base surgery. This presentation is not about getting rich. As my grandmother said, if you want to get rich, spend less than you earn. So I like to start with my conclusions in case anybody has to leave early. So leapfrogging technology, technical and technological innovation is a rewarding aspect of your career, and it can be extremely exciting. It's important to put together a team through your university and the rest of the world. Use energetic colleagues, engineers in all their disciplines and with their students, business school faculty, get to know the people in your institutional tech transfer center. Of course, learn about funding opportunities, be generous with your credit for other people and sharing intellectual property in your group. Innovate with the goal of improving your surgical practice and expect failures, but enjoy the successes. Okay, this is a really cool book. You can get it online, used for $3 or $4. Edward Wilson, Letters to a Young Scientist. It says that this is a New York Times bestseller, which I find hard to believe, but in any case, it's really cool. One of the points of the book is choose an area of novel research with few other investigators and a subject that you can make your own. If you do this, advances are going to occur more quickly. Your best chance, this is your best chance to make your mark and to experience the thrill of a discovery, and there's less competition for grants. And he emphasizes that you may feel lonely and insecure in your first endeavors. Well, my passion since residency has been both facial plastic and skull-base surgery, which a lot of people find kind of odd, but I'm going to help you understand why. Dr. Lindberg kindly went over my background, so I won't go into that further, but I've had a little bit of an unusual training. But early on, I was very early in very interested in facial plastic surgery, and particularly the periorbital, because with pretty little work, you can have a very big impact on a patient's appearance and life. And when I was at University of Zurich, I saw lots of patients with facial paralysis, and I also became interested in the effects, particularly on the lower eyelid of facial paralysis. And historically, you look at ways to reposition lower eyelid. There's wedge excisions, there's a tarsal strip. Tarsal strip can cause problems such as lid override and other issues. And then there's a temporary tarsorrhaphy, so as you see here. So I went into the lab with a colleague of mine and looked into whether there are better ways to restore eyelid support. Well, there are three main eyelid supports that you have to understand to do these things: the lateral canthus, the medial canthus, and the levator, which comes down like this. Dr. Lindbergh, can you guys see my pointer?
Yes, we can.
Perfect. So the levator aponeurosis. And a good rule is either don't mess with these, or if you do, reconstruct them. The levator aponeurosis, you don't want to damage, or you're going to have to fix it, and that's technically a little more challenging. So I was wondering if we can't reposition the lateral canthus from behind instead of making incisions in the area we're working. So we worked on a lid approach from behind the eyelid, where we put a stitch through the lateral canthus and then create drill holes through the lateral orbital wall and externalize the sutures through the drill holes, as you see here. And then you can sit the patient up. You can adjust the tension as you want here to fit the other side. And that worked pretty nicely, as you can see in this picture. Brings the eyelid up nicely. Well, what about the medial canthus? The medial canthus is tends to be overlooked, but this is where the lacrimal punctum is at the medial lower lid, and that needs to be up against the lacrimal lake, and so it's an important area. And so what can be done for there? Well, again, people do blepharophies for that, sometimes even gold weights or gold chains. Some people tighten the anterior lid, the anterior limb in the medial canthal tendon, but that actually pulls the lower eyelid away from the throat. And so I looked into the cadaver lab, and as you see, the medial canthal tendon splits into posterior limbs and anterior limbs, and between those is the lacrimal sac. And so we looked into looking deeper into the globe behind the lacrimal sac. And here we can put a stitch, or I used to use a resorbable screw in the periosteum, and then suture the other end to the medial lid just lateral to the inferior punctum. And that then takes the lid from this. Here you see the stitch in the lamina coming out, and then tighten it down, and that medializes and tightens the lid very nicely. Well, you can combine these at the same time for medial and lateral lid correction, which I call the marionette repair. So you can adjust the height and the angulation of the lid by doing this. And you can then get this kind of result. You can see the paralyzed side, I have a positive vector here relative to the other side. And that is because the lid is working as a passive sort of gutter to the downspout, which is the inferior punctum here. So that worked fairly well. Well, at the same time that I was looking at these things, I was also looking at skull-base surgery. And early in my career, in the early 2000s, I was seeing how much I could take apart and still put back together. As you can see here, we're looking at the brain and taking the Kris galley down. And some of these procedures can really be pretty invasive and difficult to recover from. So I started to look at whether there may be some ways we can be less disruptive with these procedures. For example, in this patient who has a fracture in the superior orbit, are we going to take his whole face apart to get there? Here's a lesion, a dermoid cyst in the upper outer quadrant of the orbit and skull base. And parenthetically, I ask you, is this skull base surgery or facial plastic surgery or oculoplastic surgery? Hard to say which, but you can see the deformity it causes. So I started thinking about what an ideal surgical approach looks like. Well, the approach should be short with the least possible dissection, straight with the least possible tissue retraction, noting that our equipment is rigid and we use inline viewing. It should be minimally disruptive with minimal pain and no scarring, and allow a rapid recovery. So I started to look at minimally disruptive orbital access, building on my prior work in the eyelids. And something like this is, can see in the cadaver lab. Well, we found that you could actually achieve 3-quadrant exposure without damaging the lateral canthus or the medial canthus. And this montage shows what that looks like. And by adding a blepharoplasty approach, you can actually get 4-quadrant access. And this just follows the preseptal plane up to the superior orbit. Well, it turns out the orbits could function as a very good path to the anterior cranial fossa, the intratemporal fossa, and the middle cranial fossa, as well as to the frontal sinus, the ethmoid sinus, the sphenoid, and the maxillary sinuses. And in fact, the orbital roof takes up 80% of the anterior cranial fossa and 25% of the middle cranial fossa, as you can see here in the lateral orbital wall. Well, during the same period of time, transnasal endoscopic skull base surgery was evolving rapidly. And my way of looking at endoscopic sinus surgery is that it's actually endoscopic craniofacial surgery, right? The sinuses are just holes in the craniofacial skull. And I figured I had a pretty good understanding of the lids in orbit. So I wondered if I could extend endoscopic surgery to play a role beyond sinus surgery and beyond endoscopic brow lift. So I looked at going into the lab to investigate whether endoscopic surgery in and through the orbit was possible. Well, you might ask, why endoscopic surgery? Well, with open surgery, your lighting is on your head. You may or may not have magnification. And to create an optical cavity, you have to displace the globe significantly. With endoscopic surgery, you have a very significant amount of magnification. Your lighting is in the optical cavity, and you don't have to retract the globe significantly because we use narrow pathways. And so as a result, with endoscopic surgery, we can do a very narrow, deep pathway. Well, if we enucleate the right orbit, there are a few surgical landmarks I'll go over. All of the important structures come through the superior fissure and the optic canal. This is where all the cranial nerves come through. Other than this, you of course remember that the anterior and actually medial and posterior ethmoid arteries come right at the junction of the skull base and the medial wall right here. So for the most part, the anatomy is not particularly treacherous. So here I've removed segments of bone from each quadrant of the orbit to show what you could see by going through these. And here we're looking, let's start down at the bottom. Here we're looking in the maxillary sinus from foramen rotundum. Here we're looking at the ethmoid sinus, the pituitary, the carotid. Here we're looking frontal lobe dura and middle lobe, temporal lobe dura, and the infratemporal fossa on the right side. And here's the danger zone, the superior fissure, and the optic nerve. Well, if we go just deeper into the beyond the posterior orbit, here we're looking at Meckel's cave. V1 is coming out through here in superior fissure. Then V2 is coming through rotundum. And here's foramen ovale with V3 and cavernous sinus is medial to those. So it's actually pretty reasonable to get into those areas. Well, there are four primary approaches that are required to do this. One approach for each quadrant, as you can see here. And through this, we can get into the brain, as I said, or across through the sinuses. Well, there are three types of transorbital endoscopic surgery. One is endoscopic surgery within the orbit. The other is endoscopic surgery through the orbit. And then finally, endoscopic surgery through the orbit on the brain. So in 2010, we reported on these techniques in a clinical study of 20 patients. And it took a year with 3 rounds of 3 reviewers each before this got accepted. And we called the publisher and said, what's going on? And he said, well, we're just doing our due diligence because this is unusual stuff. But this just illustrates the challenge it took to get that into the literature. Well, with these endoscopic approaches, you can get most of the craniofacial skeleton, as you can see here. Well, during the same period, navigation guidance became a real thing. And so there was significant improvement in the guidance itself, in the technical aspects of it. And I found this is great help for transorbital surgery, particularly with the complex anatomy. But we used to say the navigation only helps if you know you're lost, but I'm not sure that that's actually true. One of the things you can do is study instrument motion with navigation. So it turns out that the entire time you're navigating, the computer system is maintaining a log of your instrument position. And so if you can get into this log, you can then study how instruments move, as you see here. And so you can see what the entire procedure that you did digitally. So I thought that was pretty cool. And as it turns out, you can study instrument motion by both by location, by instrument type, and by the expertise of the surgeon. And you can look at pitch, yaw, roll, all sorts of metrics. And then you can put what we call a convex hull analysis around this, where you sort of like shrink wrapping the pathway. And you can study the pathway and see, for example, the red pathway is a novice and the green pathway is an expert. And then you can take that data to actually protect the patient. So if you know the extremes of safe instrument motion, you can create, for example, this implant here around those extremes. And this is a product that is now called the Spyway. And just a word on product development with this as an example. This can sometimes take years. The Spyway probably took maybe 7 years, and you can see it's a very simple device. Very expensive. It can cost upwards of $1 million to get 510 510K clearance for something like that. It requires an entire team, and the inventor may get very little compensation from this. But it is important to enlist the help of your friends, both in development and marketing. As you can see here, my colleagues and friends Paul Gardner and Carl Snyderman are on the board of that company. And sometimes the use may expand these products as well. It's unfortunately it isn't a great image, but here you have a patient with a pulverized nasal fracture, and you can see on profile the dorsum has dropped way down. In this case, I'll put spyways in. The spyway projects the nose, expands it nicely, and then I place a splint and suture through the splint to hold the construct in place, and that works very nicely. Navigation can play a critical aid in reconstruction. Let me show you a few examples of this. Here's a patient, a climber, who fell with roped in and smashed his face on a rock wall. You can see here we have no surgical landmarks. Well, turns out we can take the other normal side and superimpose it over the abnormal side and use that as landmarks. Now, here's a patient who had surgery and it didn't turn out well. So we take the normal side of the face, highlight it like this, flip it over and superimpose it, and then we can see where the native bone is under projected or over projected. And in an endoscopic procedure, we can then trace along the orbital wall and orbital floor here. And here you can see where the orbital floor is, and here you can see where the orbital floor should be. So all of a sudden, we have a very nice surgical template to use. Another case of revision surgery, here's an implant. You navigate the medial wall, and you can see that this is where the implant is, this is where the implant should be, and then you can adjust it accordingly. Navigated orbital reconstruction. First step, we do complete fracture exposure, lift all the contents out of the maxillary sinus, remove obstructing bone. Then we place our implant and make very sure that there's no entrapment of the periosteum or orbital contents circumferentially. Then we shape the implant in situ with some little instruments without removing it, and then we navigate it to make sure it conforms with the plan. Here's where the orbital floor is, this is where it should be, and then line it with PDS. It was a large fracture. You can see the anterior and middle ethmoid arteries here, but we didn't need to remove these. The setup for this is the same as your standard sinus surgery setup. And we did a case-controlled outcome study with over 100 patients, and we found that this technology reduced the need for revision surgery from 20 to 4% in complex cases. By complex, I mean 3 and 4 wall fractures. It's important to make sure that the maxillary antrum is not obstructed after your reconstruction. In other words, you need it to be open like this, or you get very long-term infectious complications. And it's important to make sure that your construct is symmetric at the end of the case. But again, I do this with navigation, and I don't routinely get post-op CTs. These techniques are excellent for a zygomatic maxillary complex reconstruction. Simply superimpose the normal side over the abnormal side. Do your repositioning and navigate it to confirm that you're in the right position. This is particularly helpful along the areas of the zygomatic arch, and you can navigate along with one tiny little incision over that area. Well, we can also do this type of reconstruction with frontal sinus repair, either acutely or in a delayed fashion with percutaneous osteotomies. So here's a 7-year-old child with frontal sinus posterior table fracture, as you can see here, and a massive CSF leak. He was offered a craniotomy, and the parents balked at that, and so they asked and so we did transorbitally. And here you can actually see brain herniation through this blepharoplasty incision. So we take down the mucosa. Here are the bone fragments. We remove those, and then you can resurface this however you like with Alloderm or Duragen or whatever your favorite product is. And here the patient is 2 years later, no problems, no visible incisions. Well, what about anterior wall fractures? Again, here we use the normal side as a template, do what I call mirror image overlay, and through a blepharoplasty incision, we can access that area. Here's what it looks like inside. We elevate the fractures and then place a surgical sponge behind them to support the bone fragments in the position. Here he is post-operatively, and I do these very regularly. They work great. It's also good for revision cranioplasty. You can see the patient came down with a cranioplasty from Alaska. Didn't look particularly good. This is what the construct should have looked like, and so we can go ahead and reconstruct what it should be. Well, one of the fields that I find challenging is in rhinoplasty, particularly the osteotomies, because you're doing blind osteotomies, and it can be very hard to kind of choose exactly what you want to be. So I started looking at whether we could look at analytics with navigation to study the logic and placement of osteotomies, and whether we can actually do visualized osteotomies instead of blind osteotomies. So here was a really neat gal, and she had a bit of her nose was off to the left side, but it wasn't just that it was off to the side. She also, as we say, was listing like this ship here. And so if you get a 3D CT scan, you can see that nasal dorsum is kind of tipped like this. And the distance from point A to point B is longer than the distance from point B to point C. So what do we do with that? Well, I found that it's really helpful to place the osteotomies in suture lines. When you do your osteotomy in a suture line, it's much easier to do. And you don't even have to have a sharp osteotome, which sometimes I find that I don't. And so we do our osteotomies in suture here, and then we plan an osteectomy to straighten the nose. So we're going to actually remove this triangular piece of bone. And you can see when we do that, we straighten out the nose nicely. I also took down the dorsum, but particularly if you compare these pictures, you can see where her nose is angled over. Now she's straight, and these distances are the same. Well, the setup for this is, again, the same as just standard sinus surgery. We put a navigating device on the osteotomy, on the osteotome. And then during surgery, you can actually see your osteotome going through the bone. That was a little sped up, but it's really quite rapid when you go through the sutures. Well, here's another fellow with a twisted nose. I'll have our residents tell me, ask me, I will ask my residents what exactly is the underlying problem here? What kind of osteotomies are you going to do? How are you going to correct this? And if you get a 3D CT scan, you can look and see that his nose was very significantly rearranged. And here you can see the suture sites. The nose has been pushed over to the side, but there are also fracture sites. And I do osteotomies in the fracture lines as well. So what we're going to do here is do a lateral osteotomy, but also we're going to elevate this triangular piece of bone here by doing osteotomies through the fracture and through the suture, as you can see here on the plan. And we didn't do an open rhinoplasty. We just did these navigated osteotomies here, and you can see what he got. And he was breathing very nicely afterwards. Well, what about navigation guidance in surgical planning? I'm a huge proponent of looking at vector analytics. This will show you, this will help you choose the ideal path, and it'll also help you choose whether you're going to do multi-portal or monoportal approaches, as I'll go over in a minute. It will also help you with segmentation and a global study of the pathology at hand. Well, when you're doing surgical planning, depending on the procedure, you really need to do a complete global analysis or analysis of each plane. Particularly when I'm doing transorbital cases, I'm looking circumferentially to look at the ideal pathway to get to the tumor. Well, here's a patient was referred in after another surgeon tried to do a resection of the frontal sinus osteoma through the nose, and you can see it was kind of a swing and a miss. You can see some air here. Here's a hole in the osteoma. There's also a hole in the anterior wall of the frontal sinus, which was unfortunate. Well, if you do vector analysis at the beginning of the case by using your navigation wand and extending the vector forward, you can see exactly where you're going to be able to get to through different positions. And in this case, I wanted to take down the inner sinus septum and this bone here because of a mucocele. And so transnasal approach alone wouldn't get me that. Well, what about adding a transorbital approach? So here we model a transorbital approach, and you can see the vector will take you all the way through to the opposite sinus. And this is what it in fact looked like when we're looking through the orbit across the frontal sinus after taking down the inner sinus septum. So this allows you to reassure yourself that the approach that you're thinking is going to be the right one, or choose another or multiple approaches. Well, here's a patient with metastatic esthesioneuroblastoma to the greater wing of the sphenoid here in gray. And what we do is segment that bone, highlight it, and then we can look at different vectors to make sure that through different pathways, we're going to be able to get to the entire extent. And here we use a lateral retrocanthal approach to get to the surgical goal. And this is what it looks like. Now here on the left orbit, so this is the orbital contents here. Here's the frontal lobe dura exposed. Here's the temporal lobe dura here. Here's temporalis muscle. Here's the infraorbital nerve going into foramen rotundum. So you can see we've got a very nice, complete resection with only that one approach. And here you can see the bone we removed to get that out, anterior cranial fossa, middle cranial fossa, and like that. She did fine. Well, can you use navigation guidance in discovering new pathways and new analytics? And of course you can. And one of the things I try to teach our residents is to flip the perspective. Pretend you were the tumor and look around and see how you would escape. Well, look at this type of surgical analysis. Here we put in some different potential surgical pathways, and we can visualize through each one of these pathways. Here's looking through the nose, and then we can look through the orbits like this. And you can see the bone that you have to remove, and then you can get into the tumor, and you can look around, and as I mentioned, see how you would get out. But let's look at this pathway. Here, if we look at a transorbital pathway, you see there's actually no bone in the way. Excuse me, transoral pathway. No bone at all, and that gets you right into the tumor. So if I were this tumor, I'd want to jump right out through the mouth. So what can we do with that information? Well, to get to where that tumor was in the infratemporal fossa, it's difficult to get to the inferior and posterior infratemporal fossa through a transorbital approach because this vector would compress the eye excessively, and we don't want to do that. And so if we come through the transoral approach here, it's going to show us the entire middle cranial fossa in this region. So that seems like it should be quite favorable. And so I call this the paramaxillary approach, transoral paramaxillary approach. And here we have an incision adjacent to the third molar, couple of centimeters or so. And this is the analysis of where we can get with that. And after we remove the fat and infratemporal fossa, here we can see branches of the internal maxillary artery, and we can just Doppler ahead to know where those are. And then we can see branches of V3, and we can see the temporal bone. And if we look up here, you can actually remove part of the temporal bone and look at the middle cranial fossa and the temporal lobe, like so. Here you have infraorbital nerve, maxillary artery. And if we look down a little bit lower, we can see the hypoglossal canal, hypoglossal nerve. We can lateralize the internal carotid artery, and we see the 12th nerve, 10, 9, and 11 is over here in an internal jugular vein. And then we can even look a little bit more lateral to those areas where we see the stylate process, and here we can even see the deep side of the facial nerve. And the first time I saw this was really exciting. I thought, wow, that's cool. And I've actually removed some deep lobe parotid tumors from this area, but that's another subject. So this is a patient with a tumor in that region. This is a trigeminal schwannoma going into foramen ovale and displacing the temporal lobe of the brain, as you can see here. Well, what adds challenge to the resection is that you have the petrous carotid down here, and you can see it right behind the tumor. That's a little hard to see there, but this is what the approach looks like. So again, a 2-centimeter mucosal incision. We dissect in and remove some of the orbital, some of the infratemporal fat in that region. And then we dissect until we see a branch of the trigeminal nerve, the inferior alveolar nerve right here. And then as we dissect more deeply, here's the tumor exposed. And you see this is a self-retaining optical cavity because the zygoma holds the musculature, the arch of the zygoma holds the musculature out. So we have a beautiful optical cavity here. And after tumor exposure, and we pull the tumor down through foramen ovale and off the temporal lobe. Here you can see this is the lateral aspect of the sphenoid sinus. Here's foramen ovale, and this is temporal lobe dura. And so this is what the resection cavity looked like afterwards. And I typically fill these resection cavities with a bit of abdominal fat because I don't like leaving the dead space there because you get fluid collection. So anyway, she had a complete resection. And this shows some of the tumors that I've resected through the paramaxillary approach. Well, now let's kind of look at the convergence of these different research pathways that I pointed out. And these all come together in what I call transorbital neuroendoscopic surgery, or TONES. So this involves reconstructive and aesthetic eyelid surgery, endoscopic orbital surgery, minimally disruptive skull base surgery, navigation and planning and instrument motion, and navigation in reconstruction. And so if we look at the patient's right eye, these are the different approaches that I've used: precaruncular, lateral, retrocanthal, transconjunctival, and just a preseptal blepharoplasty. And here is the what I call the danger zone. This is common to whatever approach you're using, but the superior fissure and the optic nerve are both invested in strong periosteum here. And so as long as you're careful, you're not going to damage these things because the dissections are all subperiosteal. And here are the ethmoid arteries. There's usually anterior, middle, and posterior. And by the way, parenthetically, if I need to do an ethmoid artery ligation, this is the way I do it rather than the nose because there's no bleeding. It's easy to see. So let's look at the superior approach. Again, a blepharoplasty approach. Here's the access, very short, shallow pathway. And through this, we can do endoscopy of the entire anterior cranial fossa. We can come through into the frontal sinus, as you see here, and illustrated there. Here's a frontal sinus encephalocele. We're going to do a transorbital approach here. We're looking up through the orbital roof into the frontal sinus. There's the encephalocele. Bipolar, shrink it, and then you can place any liner you want, Durgen, anything in there. And then you can go medially and look at the frontal outflow tract function. And here's kind of a fun image. As you look at this reflection, you can see the light reflection modulating from the ciliary motion. And our rhinologists have all said, yes, this is ciliary beating. And then you can see these little blood fragments dropping down. So you can see as the mucociliary transport as it comes down here. That's really cool. So anyway, you know the frontal sinus function is good. And here's the patient afterwards with a good outcome. You can also use this approach to do 270-degree optic nerve decompression, as you can see here in a patient who had a trauma. Here's a 78-year-old male with meningioma who had 5 prior craniotomies. Here you can see the meningioma there. So we do a supralateral approach to an upper bleph, dissect down into the orbit, remove greater wing of the sphenoid. Here is the base of the anterior clinoid that we've resected. Here's the orbital apex. And when we look through here, the optic chiasm is actually anterior to this. We're looking at the optic tract here, okay? Not optic nerve, but the tract. And here's the olfactory tract above it. Here's the orbital content. So this is a vector on a Roton illustration that we're looking through here. So that's really, it was really pretty fun and exciting to see that. Medial approach, we do a precaruncular incision here. And I haven't been giving references for each one of these things due to time, but you can Google any of these and you'll see papers on them or email me. Precaruncular approach, very shallow, short, gets you to the medial orbit, the lamina. And here you can do dissection from the floor up to the orbital roof. And if I have a sinonasal tumor here, I will actually go intracranial above the tumor to do my dural surveillance before I resect the tumor. And then you can put a layer such as a PDS sheet above here and make sure the brain's entirely safe while you do a transnasal resection. So you can go across the inner orbital skull base back to the orbital apex along the optic nerve like this. And this is good for a medial optic nerve decompression. And here you see we're actually doing a contraportal approach. So from the opposite eye, looking at almost 90 degrees at the optic nerve. And this is a kind of oncologic resection. Here's carotid artery that you can get through this. The inferior transconjunctival approach I've showed you, I use this most commonly for fractures, but again, this will show you the infraorbital nerve going to foramen rotundum. And here you can see a nice panorama of the fracture site. And people are actually starting work on transorbital temporal bone and otologic surgery. Dr. Janis Siller is starting to do this, and the anatomy is really pretty cool from this approach. What about the last approach, which is the lateral retrocanthal approach? And you can go behind the canthus, or you can do a canthotomy and cantholysis. Either one doesn't matter. This is the area of bone exposure. You can remove the entire greater wing of the sphenoid bone to get to the temporal lobe, or you can come over the superior fissure and you can take down the meningoorbital band, and that will get you into the cavernous sinus and Meckel's cave, optic nerve, pure foramen rotundum down there. And so this trajectory will get you the cavernous sinus, Meckel's cave, middle cranial fossa, hippocampus for seizure surgery, and the brainstem. And this is Dushik Kong's approach through meningioma. He's a phenomenal surgeon at Samsung Hospital in South Korea. This approach will also get you to lateral recess CSF leaks, as I have done in the past, and it works very nicely. So with all these different approaches, we can actually combine them for multi-portal surgery to combine the transnasal, transorbital, and transoral approaches as needed. Now, here's a patient with a benign bone tumor, and we're going to do a quadriportal approach for this. And I don't have time to go through this video in detail, but there's the incision we're going to use, and it's just a blepharoplasty incision. There's the orbital roof we're dissecting through, and there's where the orbital roof has been violated. I don't usually use a 15 blade for that, but it works fine. And then we just suction out the contents and then begin tumor removal. With a bony tumor, you're going to be using a lot of different instruments, including kerosins and ultrasonic aspirators like this. And so here we're going through a precurruncular approach on the other side and removing bone. But the kind of fun thing I want to show you is when you use multi-portal technique, as you see here. Now, this is a suction coming in through transorbital approach, and we're viewing through one transnasal approach and instrumenting through the other. And so you can see there's a great deal of room between your instruments, and you can really work together nicely in team surgery. And this one is fun. You see here we have a suction coming in from the opposite end of the drill. And the nice thing is you can suction all the material out of the way so your view doesn't get obscured by bone dust and like that. And then the last thing I want to show here is you can actually look across the skull base from one orbit after you've done a reconstruction. So this is a piece of PDS sheet that I've used to reconstruct the contralateral orbital roof, and you can look and see that there's no entrapment of orbital contents, and that works really nicely. And post-operatively, you can see we got complete tumor section. She had a mucocele that was pushing down her eyelid here, and you can see that's all resolved, and she did nicely. So wrapping up here, the types of pathology we can remove in this approach: orbital tumors, skull-based tumors, brain tumors, sinus problems, cavernous sinus, mucocele, optic nerve decompression, seizure surgery, epistaxis, and some of these other things. Well, people ask, how can this surgery be safe? Well, the volume of these pathways is about 3 cc's. The orbital volume is 30 cc's, so the volume of the approach is quite small. We retract the globe less than a centimeter, and the optic nerve has a centimeter of redundancy, so you can displace it without difficulty. But we always monitor the pupils to make sure we're not placing excessive pressure. Outcomes, the world literature have confirmed this. Houlihan did an analysis of 253 publications and found a complication rate of 13% with a negligible rate of CSF leak because the periorbitus seals the defect. And nearly all complications were transient. There was one report by Schwartz of visual decrease post-op due to a hemorrhage, and that's because they pushed the retractor too strongly in the globe. So if we look at the publications on tones, this is our original publication in 2010. You can see it was quite slow for a while. And then we had an international cooperation called the Endoscopic Transorbital Society with Spain, Italy, and Korea. And things really started to take off. And then in the last year, we all put together a book, Transorbital Surgery, as you can see here, and it's really taken off nicely. Well, if you want to learn these things, it's important to do hands-on courses and start slowly. You can go to endoorbit.com for learning resources and information on meeting. And at the North American Skull-Based meetings in February 13 to 16, there's going to be a day and a half of dissections on this and the world's experts speaking. So we've discussed some types of innovation. We've talked about leapfrogging developments and technology and techniques. We talked a little bit about product development, working with colleagues in multiple specialties, working with engineers and international collaboration. But there are challenges, of course. Accepting new procedures is difficult because a lot of people don't want to try new tricks. And so it really takes time to influence people. Patents. Well, we developed a surgical planning system for navigation that allowed an incredible amount of pre-op planning and rehearsal and like that. And one company came out to see the software 9 times after we had patents and non-disclosures. And then, without knowing who I was, they invited me to see this display they had a year later, and they showed me essentially the software that we were showing to them. So they basically stole it. We went to the UW saying, we had a patent and all the rest of that stuff. And they looked into it and said, yeah, well, they have an entire department of patent lawyers, and we're not going to fight it. Just it would take too long. So there are challenges. And looking back in hindsight, E.O. Wilson was right. You may feel lonely and insecure in your first endeavors. You can imagine when I was first advocating doing this kind of surgery, it was very lonely. But he was also right about the excitement. Thanks all of you for your time. Please contact me at this email address if you have any questions at all. I'd be happy to answer them. Thanks again for the honor of joining you. Okay, if I can stop my screen sharing.
Dr. Mo, thank you so much. That was an incredibly fascinating talk. I've gotten multiple messages from residents and faculty already saying how wonderful that talk was. We have a couple minutes for questions. I know some people have to sign off at 7:30, which I'll allow people to do. But for those that are interested in asking questions, we'll open the floor.
Hey, Kris, Jose Garola here. Fantastic talk. Can you talk for our residents and I guess even your seasoned faculty about how you found it most efficacious, let's say, on getting buy-in from the multidisciplinary factors? Clearly, you have a comfort level around the orbit that was maybe beyond the usual neurosurgical and even some of the ophthalmologic colleagues that we have. How did you get your neurosurgeons to buy in and some of our other, I guess, co-disciplinary providers?
So that's a great question. Basically, you bring people into the lab and you do dissections together. Teamwork is critical here, and I've worked with so many people on these things. And so, bring neurosurgeons into the lab and show them these things. When you do endoscopy and show them the deep orbital structures, even oculoplastic surgeon, you'll see these guys, their faces light up and they start to smile. Women too. And it's like they see how well they could visualize these things. The other thing is take your neurosurgery partners to things like the North American Skull-Based meetings and sit through the lectures together. We have international meetings every year, and we encourage teams to come together and see these. And often next year they come back with their whole team and they present their results. So teamwork, go into the dissection lab, go to courses together, and build from there.
Thanks.
Hey, Kris, great to see you. Really good talk. You covered a lot of ground because I think skull-based and what you do is a lot of ground and overlaps a lot of fields. So 2 things. One, you mentioned the lab. So do you have your own lab set up, and what is the value of the lab to you there? And then the second question is within the image guidance navigation. You know, the spyway definitely kind of sets a track for you to work in, but it also limits because it's sort of a physical restraint in the nose. Have you done any work with looking at the image guidance itself to just sort of warn you when your instruments are getting off track and kind of beep or make a noise, but not actually fill the nasal cavity?
That's a great question. And yeah, absolutely. We have done work with the software. The software we developed actually had warnings, speed warnings, structure warnings, and all of these things. And so I was really kind of surprised to see this company show us those exact things. So some of those things are down the road and coming on, but yeah, absolutely. We do work on those things, and you're right. The spyway can be limiting. It's best for pituitary surgery, and you can alter the shape if you want to use it for transorbital surgery for narrow, deep pathways. We do have a lab. We have cadavers all the time in navigation, and it's enormously helpful because we can go in the lab in the evenings or before clinics and things like that. When this meeting's done, I've got a team of neurosurgeons. We're going to go over some new things. So yeah, that's really important. But we need to. I want to go in the lab in particular with you because I know you are brilliant at these things, and I think it'd be fun to work on some things and also get a resident course going. We talk about that.
Absolutely, yeah.
Nice.
For those who don't know, Kris and I go way back. We've been going to North America. I think we met at North American Skull Base Society, and that's really where a lot of this field evolved. So when we both started practice, or maybe I think when I started and you were already in a little bit, but none of this existed. So Kris has been a real pioneer in the transorbital approaches, and the whole field has just really exploded. But it's been interesting to watch it all evolve through anatomy and through anatomy labs. But also, everybody meets yearly and kind of discusses their results. And as Kris remembers, it was not accepted early on. It was quite contentious, and several tempers flared in early meetings. So, yeah, well, thanks very much, Kris. Really, really interesting.
Absolutely. Looks like Caroline has her hand up.
Yeah, hi, Kris. I'm one of the general otolaryngologists here. I had a question for you in terms of maybe young investigators, in terms of maybe tips that you have to kind of go from good idea to actually getting some funding for like a minimal viable product or the software. Like I feel we have great surgical skills, but getting buy-in from very expensive engineers and programmers can be difficult. Do you recommend making academic connections to try and lessen the monetary cost, or what other tips do you have to try and get that skill set onto your team when you don't necessarily have the reputation you or Ivan have to convince people to join you?
Great question. I recognize that's a challenge. One of the things is making friends with engineers and making colleagues. You may need to look through and ask around and see who's interested in that. But I'm sure you'll find engineers and academics who are just dying to do this kind of thing, and our graduate students in particular are very interested. And the engineers become great avenues for funding as well, because it opens things up like the NIBIB, the National Institutes for Brain Imaging, like that. They're very great partners in getting funding. So basically, talk to people in different specialties, ask around, see if there are other people that you don't know about in engineering. And they're going to be a great source of funding when you partner together. Then, for example, in Washington State, we have tobacco money that's really accessible for innovation. It's called Washington Research Fund. I think you guys must have things like that. But partner together, form a group, find people at university who are interested. Also, people in industrial design are helpful. You can pitch these things to engineering students and business students who will take these on as projects and can do a lot of free or low-cost innovation on them. So anyway, great question. Yeah, good luck. Feel free to email me or call me if I can do any coaching.
Thanks so much.
Thank you. Well, Michael, it looks like we've answered most of the questions, and I'm looking forward to seeing you up here.
Oh, yeah. No, actually, we're just there this past weekend. I went with my wife and my son to kind of scope out the area. A little rainy, but it was beautiful. We loved it. So I do look forward to seeing you.
It's been
so much. Everybody, honestly, I really loved your talk, and we're just so grateful that you made the time. And I know you have these connections with so many of our faculty, so they were very happy to see you today. Well, I had a quick question for you, actually. Do you know, is it possible to create, you talked about using navigation to create symmetry when you're working, with like orbital fractures or ZMC fractures to make sure you have symmetry. Are there ways to actually do surgical planning so that the plate itself can be registered so that you can make sure that you're in the right vector? Because I've been in many trauma cases where we kind of place the plate, look at it, we're like, oh yeah, that looks like it's symmetrical. That looks like that'll be good enough. And I'm just curious if there could be a better way of doing that, because it sounds like with the surgical navigation trauma, you're using the navigation probe to look to see if you're symmetric. But wouldn't it be nice if you could just actually have something that could, when you put it in and drill it in, you're like, yes, this is keeping me honest. So I don't have to worry about like a post-op CT or something if things are a little funky.
See, that's an awesome question and illustrates the way you think. And asking that kind of question and thinking that way is the type of thing that's going to give you a phenomenal research career. And when you come up here, we should talk about that more. Randy Bly at Children's, I don't know if you met him, I work with him all the time, and he's phenomenal. The answer to your question is yes, there are ways of doing it. Craniofacial trauma, the techniques have not improved in my entire career. It's little titanium plates, right? I mean, essentially, years nothing's happened. And what you're talking about is the same thing I've told these major companies. If you want to get a step ahead and make a better product, you got to think about exactly your question. So the answer is yes, there are ways of doing those things, and you can integrate those things into your navigation system. They're not yet available. There's good ways to do it. There are workarounds. You can navigate the adjacent bone right now and see if the bone's projecting the way. You can also, if you need to, get an intraoperative arm or CT scan, but those things take time. But yeah, you're asking the right questions. Those things can be done. They can be done with industry. The problem with industry is selling products to the private practice guy out in the community, and they aren't doing the things that you're doing. And there's a principle in development called the least functional unit. So that spyway product, we wanted to put lights on that, irrigation on that, all sorts of stuff. I mean, I wanted a disco ball and music play. But the CEO, who was a friend of mine and took it to market, said, it's got to be simple, it's got to be cheap to produce, and you got to be able to sell it with a good profit margin. So
I'll pay for the disco ball version, Kris.
The bottom line is, I'm gonna say this week. We'll do that.
Bottom line is that navigation units work, and the vast majority of people don't want to go beyond that. So there's no pressure to evolve.
Yeah, makes sense. Cool.
But you can change it.
Okay. Well, thank you. I'll be fixing all the pediatric faces with that then. Thank you so much for a wonderful talk. I really appreciate it.
Thanks all of you. Hope to see you soon. Take care.
Yeah.